Michael and I come to High Oakham Primary School, and my daddy is a police officer, and I like it when Joe Wicks is Scooby-Doo. Hi, my name is Lacey. Hi, my name is William, and we go to High Oakham Primary School. And I like playing with the marbles one. I like playing on the field with my friends. And my daddy works at the police. My mummy is a teacher.
Hi, I am Joshua, and I go to High Oakham Primary School, and my dad is a key worker, and my mum works for Boots, and I love the field. Whoa.
Hello, I'm Charlotte, and my parents both work for Nottinghamshire Police. My favourite thing that I've done at school so far is rounders.
Hi, I'm Leo, and my mummy and daddy work for the ambulance services, paramedics. They take people to A&E when they've had an accident. I have been at school recently, and my favourite thing has been weaving Eye of God. Here's a picture. That's all from me, and this message is to say stay home, stay safe.
Hi, my name is Ethan, and this is my brother Johnson. My mum and dad work for the key workers of police force. Our favourite singer at High Oakham Primary School is Rounders.
Thank you, County Council, for keeping us safe.
People, all the key workers who are working during this pandemic. Thank you, Mum and Dad and the school. My favourite thing is so I can play with my friends.
Me. Thank you for Miss Lowe, and thank you for Miss Smith. And we had lots of fun with belly dancing and painting rocks.
Thank you for keeping our school open. Mr. Bancroft and the cleaners are all fab. I'll have a lot of special memories here.
Thank you to Mrs. Thompson, Mrs. Pye, Mrs. Sheila, Mrs. Kayla. We've been painting, we've had ice cream, we've been outside, and we've even had Easter eggs.
Thank you for letting us in the school while my mummy cooks the dinners. We made fairy gardens, and we played on the bikes, and the teacher made it lots of fun, and we made lots of new friends.
My mummy and daddy work for the NHS. My mummy and daddy work for the NHS.
My mum and dad work for the NHS.
Our mum and dad work for the NHS.
My mum and dad are on the front line risking their own lives.
We want you to stay at home to help save lives.
We want to protect our family and would like you to protect yours.
This virus can kill anybody.
You may not have symptoms, but you could still be spreading the virus.
It's important to stay at home and help save lives.
I'm Gemma, and this is my husband Paul, and we're both foster carers. I think initially we were a little bit anxious ourselves about going to panel. It sounded quite scary, but it wasn't at all. It was just a really friendly chit-chat with a group of people around a table. It was more of a celebration really of us being there and of us, wanting to become foster carers. The County Council offer a fair rate of pay, so we get paid dependent on our level of experience. So after you've done it for a while, then your level of pay will go up based on your experience and level of training that you've done. We've also got a network hub, which is a foster carer support group, and it's just an informal get-together. We feel so valued as a foster carer for Nottinghamshire County Council. Everyone's so caring and wants what's best for you as a family. The matching process is really careful, so they listen to our needs, and they would never think of placing a child that wouldn't fit in our environment. As a foster family, we try and just make it everyday normal life, try and bring some stability and love to that child that's staying with us, and give them experiences that perhaps they've not experienced before. We love going out on day trips together, and for example today we've gone pony trekking. Nottinghamshire's a great place to foster because we've got so much on our doorstep. There's so much that we can do. I feel really lucky that we're able to foster here.
There is no doubt that without the support from Shared Lives carers, Joe's family would probably have ended up in crisis. But with the support of Julie and Yvette, the family do not have to cope alone, and they now enjoy quality time with Joe on a regular basis.
Helen and Mike's care has been fundamental to Daniel's development, safety and happiness, and my peace of mind. They have been sensitive to Daniel's challenges and needs, as well as myself and my family. I am now widowed, and their support is utterly essential to me and my other son in making us feel Daniel's needs are met. I'm continually in awe and appreciation of the work they do for my son.
Chantal loves visiting Hayley. She says it's fun and exciting. She gets to spend time with someone her own age. Hayley's such a lovely friend to Chantal. The family now have time to go out for meals, walk the dog and just chill.
Family members closest to Sarah have been able to gain great comfort and relief from the fact that Sarah has found a new family where she is happy and enjoying life to the full. The support that Sarah has received from Kelly and Ross have given her own family the time and space for them to better cope and manage through the difficult times.
Gemma's support means everything to Sophie and I. Sophie loves staying at Gemma's and does a lot of different things when she's there, and she's very helpful too.
Good morning, everyone. I would like to welcome you all to this meeting of the Adult Social Care and Public Health Committee, which is being held remotely, with the majority of the 11 members joining the meeting from their own homes. I'm Councillor Tony Harper, and I am chairman of this committee. This is the first virtual meeting of this committee to be held in line with the new requirements of the Coronavirus Act 2020, so do please bear with us. So we'll move on to item 1, And item 1 is to note the appointment by full council on the 11th of June 2020 of myself as chairman and councillors Boyd Elliott and Francis Purdue-Horan as vice chairman of this committee for the 2021 municipal year. Anyone abstaining? Anyone against? Thank you. That's been agreed. Item number 2, membership of the committee. Item 2 is to note the membership of this committee for this municipal year. The membership is councillors Joyce Bosniak, Dr John Doddy, Boyd Elliott, Sybil Fielding, myself, David Martin, Francis Purdue-Horan, Andy Sissons, Steve Vickers, Muriel Wise and Yvonne Woodhead. Anyone abstaining from that, please? Anyone against? Thank you, that is carried. I can confirm that all members are present today. We also have the following officers present: Melanie Brooks, the Corporate Director of Adult Social Care and Health, Jonathan Gribbin, the Director of Public Health, Sue Batty, Service Director, Community Services, Ageing Well, Ainsley MacDonald, Service Director, Community Services, Living Well, Grace Natalie, Director of Transformation and Service Improvement, and Jenny Kennington, Senior Executive Officer. And we also have the clerk to the meeting, Sarah Almond. And I'd just like to thank Sarah for all of your hard work in pulling it all together. Thank you. Item 3, minutes of the last meeting, 16th of March, which seems a lifetime ago. We need to ask the committee if the minutes can be agreed. Could you all, anybody against? Anybody abstaining? Thank you, that is carried. Item number 4, apologies for absence. I'll just ask the committee clerk if there are any apologies or substitutions, please.
There are none, everybody is present.
Thank you. Number 5 is declaration of interests. Do any members or officers present have any disclosable pecuniary interest to declare? And do any members or officers present have any private interest, pecuniary or non-pecuniary, to declare? And as I always say at this point, if something crops up in the agenda later on and you do find you have an interest in it, then that's fine. Just let us know then, please. Item 6 is the response to the COVID-19 in adult social care and public health and future priorities. The report accompanies presentations to the committee on the departmental response to the COVID-19 pandemic, key decisions and actions undertaken during the emergency response period, and future plans for recovery and transformation. Presentations will be given by Jonathan Gribbin, Sue Batty, Ainsley MacDonald and Grace Natalie. The recommendation of the report, as set out in page 12 of the agenda pack, is that members consider whether any further information or actions are required in relation to the department's response to the COVID-19 pandemic and decisions made during the period March to June 2020. I'll formally move the recommendations. Do I have a seconder, please? Councillor Elliott, thank you. Councillor Martin, I notice you've got your hand up. Councillor Martin?
Yeah, it's a question for later on, sir.
Oh, right, okay, thank you. Jonathan Gribbin, would you like to start the presentation, please?
Good morning, everyone. And I'm going to start off by asking Jenny. Oh, she's there already. You should see on your screens what I can see on mine, response to COVID-19 public health. Councillor Harper, please tell me if that's not visible to people. I'm going to cover off a number of things related to public health's involvement. Next slide, please. But starting off, first of all, with a bit of an update for you about where we are at in the course of the epidemic at the moment within Nottinghamshire. So in the context of the last 4 months, happily, we're over on the right-hand side where you can see that the number of confirmed cases now is much lower than it was back in early April, late March time. And in fact, in the last 7 days, the information I have from Public Health England yesterday was that the number of confirmed cases in Nottinghamshire were 15 over the last week. There are no care home outbreaks reported. And if we look at district level, we see that the numbers are plateauing or reducing slightly across all of our districts at the moment. And that's all of that is good news. It's worth, nevertheless, just reminding ourselves that the cases that get confirmed are in many ways the tip of the iceberg. Most people who get infected with coronavirus are asymptomatic, and we're not currently testing people who are asymptomatic. So there's a lot more coronavirus circulating out there in the community than we see reported here. And that provides us a relevant prompt, really, that the relaxation of measures that we've seen recently, that needs to be balanced very carefully against each of us continuing to comply with the social distancing, self-isolating if we get symptoms, with the frequent and rigorous hand washing, and so on. Next slide, please. Public health over the last 3 or 4 months has been involved in a number of ways. We've been very involved both within the council and working with partners to interpret the national guidance that has come out. We've also been very involved across the LRF in a number of its cells, indeed leading several of them. So I chair the tactical coordinating group of the Local Resilience Forum and attend the strategic coordinating group. Members of my team are involved in the humanitarian assistance group, in the local authority cell. In those groups, they've contributed in particular to arrangements around establishing the community support hub and making sure that we've got good arrangements in place for people with complex needs. We've also contributed significant resource to the data and information cell that the LRF has stood up and which has provided information to decision makers across the local system. We've contributed very significantly to the logistics cell, in particular working around on PPE, also to the testing cell and care home cell. And I've mentioned already the work around PPE. Happily, it's not something that we've had to give the same sort of focus to now as we had to back in April, but there was a lot of very intense activity at that time. The situation around PPE now, I'm happy to say, is much better than it was back then. The supply chain for PPE relative to this time last year is still extremely disrupted, and for the time being we continue to receive LRF drops. Nevertheless, we're in a much better position now than a couple of months ago. And then of course we've also involved around local outbreak control planning, which I'll come on to at the end. Next slide, please. So over the last 3 months or so, we've initially put in place some revised delivery models for the services which we identified as being critical, and those plans included arrangements to make sure that we were able to address any increased demand or staff shortages. We paused some non-critical services so that we were able to redeploy resources across those services which were deemed to be more critical. We stepped up our arrangements around the reporting and monitoring of risks. As I mentioned, we also redeployed a number of staff, and I'll give you a couple of examples of that in a minute or two. And we also made some investments with the public health grant in relation to needs arising around COVID-19, and those are listed in the report. Next slide, please. So one example then of where we've redeployed staff would be to the domestic abuse agenda. And in particular, we deployed 2 public health staff to Notts Women's Aid. And if I may, I just wanted to share with committee the feedback that we got regarding one of our members of the team deployed there, Rachel Edworthy. It could equally, in fact, similar comments were also made of other members of staff, and I'm very confident to say that had we seconded anyone else from my team, similar feedback would have been received about them as well. But this was the feedback we received. From the beginning, Rachel's gone above and beyond in preparing herself for the role. She's shown enthusiasm, passion, compassion, and courage within the work she's done, taking on more complex casework than we would have expected. Rachel communicates well, asking questions for her own knowledge and understanding, as well as for her clients' benefit. And the feedback went on and finished up really. Thank you for your hard work, Rachel. You've made a real difference to some very vulnerable women and children. And I think that's testimony to what we've been able to do as a department, as a division, to support a really critical service at this time. Next slide, please. This a couple of slides here which point us forwards to some of what we see emerging in terms of trends in need and demand for Public Health Commission services. Around substance misuse, we've seen an increase in those coming to treatment for opiate use, so that's really great news. We think that that's probably most likely to limitations in supply for them, and we've been pleased so far to be able to receive those into treatment. It's anticipated, actually we yet to see this materialise in concrete terms, but it's been anticipated that we'd see an increase in presentations for alcohol misuse after lockdown as people get back to something more like normal living. Domestic abuse, I think this has received a lot of prominence, and you'll be aware of the problems that survivors experience in accessing support during lockdown, and of some of what we put in place, which I think no, we don't come on to that. So let me just remind colleagues that we made an investment in some temporary emergency accommodation, which provides additional capacity for people fleeing domestic abuse in Nottinghamshire. Next slide, please. Mental health and wellbeing. There's been an increase in referrals to self-harm services and also in referrals to children and young people emotional wellbeing service. We're also aware of some of the potential for trauma for staff involved in direct care during particularly in the early weeks and months of the epidemic in Nottinghamshire. And then finally, just to mention around health inequalities, which has also received a lot of national prominence. You can pick up the points there that are set out. I might just mention in addition to that that the recent Public Health England's report around the impact of COVID-19 on Black and minority ethnic communities in particular highlighted that people from the Bangladeshi community are twice as likely that the risk of death is twice as high as it is for the general population. For other groups, it's also higher than average, ranging through from 1.1 times higher for people from the Black Caribbean ethnic backgrounds, up to 2 times higher for people from the Bangladeshi group. And of course, there are other inequalities as well. Mortality for men is twice as high as for women, and mortality for people in the most deprived areas is twice what it is for those in the least deprived areas. Next slide, please. Briefly to mention that there have been some additional opportunities for us to improve and protect health during coronavirus. One would be around Quit for COVID. Of course, COVID-19 is a respiratory viral infection affecting lungs and airways. People who smoke have an increased risk of contracting respiratory infections, and when they do, tend to experience symptoms which are much more severe. And so this has provided us the opportunity to promote our Stop Smoking work. And that's we've been approaching that working through our integrated wellbeing service, which was mobilised and launched during the early weeks of coronavirus, and now working with, amongst others, Notts Healthcare Trust around this. Next slide, please. Very briefly then, to talk about local outbreak control planning. I think you'll all be aware that upper tier local authority areas are required to produce a local outbreak control plan centred on these 7 themes, which I won't go through line by line. And at the end of June, we published our local outbreak control plan. The oversight of that is provided by an engagement board chaired by the leader of the county council, and the engagement board will meet for the second time this afternoon to review those arrangements. And next slide, please. Finally, just to mention then something around the oversight and governance around local outbreak control planning. The dotted line in the middle of this diagram is intended to identify to you some of where the daily work goes on. So daily there is a meeting of an outbreak control cell, and the surveillance information is reviewed there to identify whether there are any causes for concern, any outbreaks that require particular action. So that's very much the work that goes on a daily basis. Beneath the outbreak control cell, a number of subgroups continue to do work to strengthen and improve the local outbreak control plan, which we published at the end of June, because it's a living document and there's various parts of it that can be improved on, and indeed we're still awaiting some further information from government in terms of action cards for dealing with particular outbreaks in particular settings, and as and when those arrive we'll incorporate those into the local outbreak control plan. And then at the top of the diagram, this is just to identify to you that oversight is provided both by the Local Resilience Forum, which I mentioned right at the start of this, and Melanie Brooks is a member of the Strategic Coordinating Group for the LRF, and also the Engagement Board, which I mentioned, which is chaired by the leader of the council. And there is a separate engagement board for county and for city, but much of the day-to-day work goes on within the emergency response framework of the Local Resilience Forum. And that brings to an end the things I was going to cover this morning.
Thank you, Jonathan. Before I open up the floor, I'd just like to publicly thank you, Jonathan, Rachel, and all of your staff for all the hard work you've done during the last 4 or 5 months. I know it's been a 24/7, you've been on call, you've been out all the time, and I'd just like to publicly register my thanks for all the work you've done. So I'll now open up the floor for debate and ask members to indicate if they have any comments or questions, and I've got Councillor Martin, please.
Thank you, Chair. Yeah, I'd just like to reiterate your words there. Yeah, we'd like to especially thank all the staff during this difficult time. It's been a very, very stressful time for everybody. My questions really are more about hospital discharge, and the discharge to assess scheme that was rapidly implemented. So I know you might not have all the figures immediately, but I'd like to know how many care homes took in NHS patients to free up acute beds in the county from the 19th of March. And were any care homes offered cash incentives, as they were in Birmingham, to take patients in a hurry so that NHS beds could be freed up for critically ill patients? And what checks did we carry out to see that these patients had contracted or had not contracted coronavirus? Was it compulsory that anyone moved was tested at the time? Bearing in mind that the government changed the discharge to assess scheme from 48 hours to 3 hours rather rapidly. And do you believe that that increased the risk of exporting coronavirus to some of these nursing homes? To your knowledge, how many patients moved from hospital to care homes from the 19th of March? How many of those did subsequently test positive for coronavirus? Because I think there's a distinct link between the rapidity of moving people from hospital discharge to assess into care homes. So I know you might not be able to answer them all immediately, but they're the questions I have. Thank you.
Thanks, Councillor Martin. If you don't mind, I think it would be better for adult social care to answer that one, unless Jonathan's got a burning reply to give you. But if not, I think we'll go on with the other presentations, and then Councillor Martin, I think you'll have the right person to be able to answer your question, if that's okay. Thank you. Sue Batty, Service Director, Aging Well, please.
Hi, good morning, everybody. So I'm just going to talk about some of the things we put in place during the first phase of the emergency response, and also some of our priorities across.
Excuse me, Sue, I did have a question. I did have my hand up as well for Jonathan.
Okay.
Yeah, okay, Muriel, if you want to ask Jonathan your question, please.
Thank you. It's about the, out of interest really, in paragraph 6, you mentioned 3 organisations that provide mental health services. I'm not that aware of when they were commissioned. It's about the Tomorrow Project, Harmless and Couth. Are these county-wide services, and you know, have we commissioned them for a while? And the other question is a broader question, but applies to the whole report. You speak about the increased risk of the virus to the BME communities, and I just wondered what you think about collecting the data on ethnicity and the protected groups, how that's being collected, and how we can make best use of that information in directing public health in the future. Thank you.
Thanks, Muriel. Jonathan, please.
So regarding the 3 organisations to whom we've given extensions to funding, yes, those are county-wide arrangements, and those are services that we've had in place for some time. I can't tell. I'd need to go back and double check for you, Councillor Wise, about exactly when we started commissioning them. But yes, it's essentially ongoing funding. And your question about increased risk to people from black and minority ethnic backgrounds, the recommendations from the Public Health England report, I think the very first recommendation from memory relates to mandating comprehensive and high quality ethnicity data collection and recording right across the NHS and social care, and including it at the time of death certification. So that is not in place at the moment. I'm afraid that in the information that we're now receiving from the NHS test and trace system, information about ethnicity is very poorly recorded. In fact, it's incomplete in most cases, and where it is recorded, it's not recorded using standard categories. So I regret to say it's of a very poor standard at the moment in terms of test and trace data.
Okay, Muriel.
Well, I'd just be interested in. I know you've had a lot on. Yes, like the others, I appreciate all that you have achieved. I just wondered how soon do you think? Because in every report we receive, we have the implications for service users, and sometimes that is quite thin anyway. But I just wondered what sort of time scale you'll be working with to make that that particular aspect of any report work more effectively and give us more effective information to focus our services.
So I think that the question is entirely relevant, but I'm going to have to say that actually this is largely about data collection within services which fall outside the remit of the county council. So NHS in particular, and if we're thinking about the test and trace system, the NHS test and trace system. So whereas I'd like to be able to come back to you with an answer about a timescale, I'm going to have to take that away and see if I can come back with something more concrete. I know that efforts are underway to improve the data all the time, but what I'm not clear about is at what point in time we could reasonably expect it to be of a decent quality.
Thank you, Jonathan. Councillor Doddy, is this a question for Jonathan for Public Health?
Yeah, I'm hoping so, because that's the meeting that I'm joined in. So unless I've got the wrong platform, I should like to think so.
No, you're definitely on the right platform, John.
Thank God for that. Anyway, I think, thanks very much, John. I think we have been exceptionally lucky in Nottingham. I think your job might have been a whole lot more difficult if you were stuck down in Tower Hamlets in London, or perhaps somewhere different, because the number of cases we've seen has been quite low. You did talk about opportunities, and it is interesting to see that you know, every cloud has a silver lining. That you thought that there might be an opportunity to work on people stopping smoking with COVID, being as it was respiratory. I saw an interesting thing suggested recently that we perhaps had missed an opportunity in terms of sexually transmitted diseases. That with people in 3 months lockdown, sexual activity potentially amongst sporadic interactive people was at its absolute lowest, and somebody suggested it would have been a fantastic idea to treat everybody for chlamydia and to actually eradicate some sexually transmitted diseases from the community in a way in which we've never had the opportunity ever before, and I wondered what your position on that would be. I'd like to know about antibody testing. Nottingham is particularly low on antibody testing at the moment, whether or not you feel that we should be ramping it up, whether or not we should be doing more, whether or not frontline workers should all be tested, etc. Other counties, particularly Derby, appear to be quite a long way ahead of us. Also, I was interested in how the system shut down in terms of ABL, in terms of alcohol and smoking, in terms of all the services we provide. And although we went into a critical phase, what phase are we at now in terms of recovery, and what is the re-establishment of services going to look like, and what's the time frame to do that? I hope some of those are in your remit. Take the ones that you like and discard the ones you don't like.
Okay, thank you, Councillor Doddy. I'll have a quick shot then. In terms of the Public Health Commission services, I'm pleased to say that almost all of our services are now stood up again, and in all but I think it was 5 cases, we've got some minor services, but all of the major services are now running to a modified service service model to take into account social distancing and so on. So I'm pleased to be able to report that. In terms of antibody testing, the rollout in Nottinghamshire, I think you said that it was low. I'm not sure whether you meant in terms of uptake of testing or in terms of the positivity.
In terms of the number of tests, the number of positive tests is fantastically minuscule. You can count them on your toes.
Yeah. Yes. Absolutely. So I guess we're pleased about that. And my understanding is that a significant constraint on its wider rollout is around the capacity of the system to be actually processing the tests. So irrespective of its value, actually, you know, we're constrained in any case for the time being. Thank you for your comments around chlamydia. I have to say, I do recall seeing something back in April time around this, and I haven't given it any further attention, Councillor. I'd be pleased to give it some further attention now, but I suspect that we've missed the moment that you are actually identifying.
Thanks very much.
Thank you, Councillor Doddy. Councillor Bosniak, Joyce, please.
Just 2 questions for Jonathan, and I know he's heard these before as well. But one of my concerns is the accuracy of the data that we're being given. And in fact, this morning on the news, the Mayor of Leicester was talking, saying that if they were given more accurate information that was pertinent to the localities, then they could have prevented this outbreak and the closure of Leicester. So I'd like to know whether we are getting that level of detailed information yet, Jonathan. And secondly, the accuracy of the recording, because I think I said either to yourself or Melanie that it's great to hear it's good to hear there was only 15 deaths, even though it's appalling that there's any. But one of the things that concerns me is that I was told by one of my constituents that his mum died of coronavirus, but the GP recorded it as old age and frailty. So just those questions about data, really.
Thanks, Jonathan. So briefly, in terms of the reference you make to Leicester, it is true that if we go back several weeks, local authorities and directors of public health were not receiving the level of information that we needed to be able to manage things within our areas. And it was, it's no great secret that directors of public health for some time have been asking for that information. And I'm pleased to say that over the last 2 or 3 weeks, that flow of information has now been coming through. We'd like weekly feeds of data to become daily, because clearly there's something about frequency in this. You were asking about the accuracy of the data. If I think a bit more widely about the quality of the data, in terms of its completeness, I think you will have you'll be aware that we're now also receiving what is referred to as Pillar 2 data, so test results that have been done out in the community, not just those that have been done in a hospital, in an NHS setting. So that's good. So the data is now more complete than it was. Nevertheless, we'd like to know have more information about how many people were tested at all. So not just the ones who were found to be positive, but what were the total numbers tested. The quality of the data in general, I've made some comments on this already. In some areas, I think the quality of the data is pretty good. Actually, we are good at being able to count people who've died. There are, in some instances, some grey areas and some stuff to work through in terms of what was the cause of death, and there may be a very relevant concern that you've got in a particular case there. But in general, the quality of the data that we're receiving is improving. In terms of a very specific comment that you made, I think I mentioned earlier on in my presentation about 15 people. These were 15 confirmed cases. This is not 15 people who died in the last week at all. This was 15 confirmed cases. So what I want to paint a picture of is a situation where the data that we're receiving now is much better than it was a month or so ago, but it's not perfect yet. And there's a whole load more that we're still asking for, which will strengthen what we're able to do around local outbreak control planning.
Thank you, Jonathan. As there are no more speakers or questions, I'll move on to Service Directors Sue Batty and Ainsley MacDonald, please.
Thank you, Chair. Good morning. So I'm going to start. Could I have the next slide, please? So I'm first just going to talk a little bit about what we put in across the department to respond to the COVID emergency. Then I'm going to talk a bit about ageing well priorities. We'll take some questions at that point and look at the hospital discharge question in a bit more detail before Ainsley talks about her area. So across the department, although the government did put in place a process by which we could request to not have to meet all our duties under the Care Act, that was called the Care Act easements. Positively, we haven't enacted any of that in the department. So we've continued to perform all our functions, assessment, reviews, safeguarding, including doles. But it has been at different levels because obviously very early on in the emergency we were getting very little new work, for example, but that has changed over time. One of the things we've focused on is individually risk assessing everybody that we know within our services and focusing on those that we know to be most vulnerable in terms of following up and checking that they are safe and well, and making sure that we're offering alternative types of support. One of the things we've done, Ainsley will talk a little bit more in hers, but we rapidly opened extra capacity for 64 short stay beds, and that included temporarily reopening Bishop's residential care home, and we also repurposed a lot of short break schemes. That helped us over a period where we had a lot of our social care providers, both accommodation based and domiciliary care, who were experiencing staffing difficulties, so they didn't have the capacity in their services. We did design and implement complete new emergency processes that, and including, as has been mentioned, a new hospital discharge process. And that enabled us to move people out of hospital and to create some capacity for the expected surge of people going into them. And we did that by redeploying a lot of people from areas within the department into the hospital discharge teams and also into our start reablement service. So there was a lot of work, and staff really worked tirelessly to put in place all the new workflows and things that were needed for that, but also streamlining some of the quite cumbersome processes that we did have in place. So that was really positive, and staff have given us really good feedback on that. And another real positive was we designed a lot of new live dashboards. You can imagine that there was a lot of information coming in from all our providers about risks, their staffing levels, PPE, etc., as well as our own services. So we put in place some dashboards that helped us to manage that and inform daily meetings to look at what the level of risk was and what action we might need to take that day to resolve that. Can I have the next slide, please? Clearly, carers have been under a huge amount of pressure, and we have continued to support our carers. Most of you will be aware of the Nottinghamshire Carers Hub. They've continued to offer the same sorts of support, but by virtual ways. So they've been doing team and Zoom drop-ins and group sessions and one-to-one calls to people. And there's some work underway now to look at alternative forms of support as carers' needs tend to increase the longer the emergency goes on. So instead of maybe respite in a building, can we take people out, provide one-to-one in the home, and how can we use technology, etc., to support us? Can I have the next slide, please? So these are priorities that run across both Ageing Well and Living Well for the next 6 to 9 months. Obviously, we need to continue to support people and the carers as we're coming out into the recovery phase. And it is quite a different world. We're all working and living with an element of COVID-19. Certainly, I live in Leicester, so it's not moved on quite as much for me here. But what we are doing, we are looking at we're developing a plan for review. So we're starting to see who might be the next level of priority for us to contact them and bring that work forward and check that they've got the support that they need. We've, in terms of recovery and planning, across both of our areas, there's been a lot of positives in the things that we've put in place rapidly to cope with the emergency. So there's quite a lot of things that have taken us in the direction that we wanted our services to go anyway. So there's a process of deciding what we will keep, stop and enhance, and we'll talk a little bit about that in future slides. You'll be aware that we had a big remodel of the workforce across the department, and that was due to be implemented on the 1st of April. And obviously the timing of that was terrible with the emergency. So we had to put that on hold, but we have made a decision that that will now be implemented from the 1st of September, because it will actually help us as part of our recovery work and be more sustainable as we go into the winter. So we're working with all our staff and managers on that at the moment. One thing that was really positive for our services, because we've never had this sort of capacity available at the scale for people that we support in social care before, was the Community Support Hub volunteers. So they've not been only helping with more practical tasks such as shopping and getting people's medication. It's been amazing what's happened in terms of reducing social isolation, and that might be through virtual means, telephone calls, etc. But that's something that we definitely want to keep and is part of the humanitarian assistance group work. We've all got much more used to, as we are doing this morning, to using different types of technology, both Teams, but also for interacting with the people that we support. We're doing a lot of assessment work virtually, wherever we can, but still doing home visits with all the correct equipment, for example, where we can't gather the information or make decisions about risks, etc., without doing that. But we've also developed new ways of information sharing with partners that we've done a lot, as colleagues might remember, with our interoperability sharing with health colleagues, but we've not got that across the piece. So we found it really valuable during the emergency, but also aware we need to roll it out more. And we're also looking at how we can build the more virtual options into our overall support offer, because it's just not a question of one size fits all, but some people, some carers, for example, really appreciate the virtual groups, whereas others would prefer still the face-to-face, but it's important that we're offering both. I mentioned before that some of the streamlining and simplified processes were really positive, and we had a big programme of work that we had to put on pause when the emergency hit, so we're standing that up again because that's been really well received, and it's freed up staff time to do those interventions with people rather than being putting in information and processes to organise things. Can I have the next slide, please? So I'm going to go on now to ageing well priorities, and I just wanted to start with a story because it emphasises the importance of why providing a community-led decision at the point of hospital discharge and making sure that we get OT-led reablement into people where that's appropriate is really important, and also how important a person-centred strength-based approach is rather than a sort of standardised approach. So this is a story of a woman who'd been in hospital for 3 months. She'd had a lot of multiple health conditions, and she was discharged home with support from our short-term assessment and reablement start service, and she had a package of equipment that was arranged by the hospital OT, and it was a standard profiling bed with rails that she had in place. When she went home, she began then over the night to need frequent trips to the toilet, and she was really worried. She felt she was losing her dignity, and she was concerned that she'd start to lose her independence. And she didn't want to accept health's offer of a short-term assessment bed for her to go into. So our START occupational therapist did some really detailed work with her to understand her range of movement, and it was to the level of detail that she could only lift her leg, for example, 9 inches. And then she sourced some specific equipment, a low-level bed and a lever that this woman could actually use herself. So she managed to be able to get in and out of bed herself. So she stayed at home and she's maintained her independence, kept her dignity, and she's able to manage overnight herself without requiring any support. So the case study is really important about how that knowledge about what we can put in place and the risks that we can manage in the community is for people whenever they've had a period of ill health. Could I have the next slide, please? And that takes me on to the hospital discharge model, and these are the things that one of the things we really want to keep and embed as we go forward, and we're working with our health partners on how we do this. We're also expecting some further national guidance shortly. So the integrated community discharge hubs that we had to set up very quickly meant that we have that community health and social care led decision making on what people require at the point of discharge. We also had oversight of all the capacity across community health and social care, which was really key when we had a lot of issues within our own provider capacity in terms of how we could do that. It also enabled us to support our providers because we were understanding where there was pressures on our providers, and those community teams were a good place to link into some of the support, such as infection control teams and our own quality and market management team. Also fundamental to the model is discharge to assess, and that means that no decisions made about anybody's ongoing care till they're home. So the decision is about what does it take for the person to get home for the next couple of days, and then we'll arrange somebody to go out and visit them at home, and they'll assess, have they got any, should we put in some more reablement for them, or do they need a Care Act assessment? We are doing a joint assessment at the moment of the resource that requires, because obviously at the moment we've made that capacity through redeploying staff, through temporarily funded staff with the NHS funding that's available for that. And also we've actually had to redirect quite a lot of our community capacity to the hospitals. It has been a success story though. More people are going back home rather than into a bed, and more people are leaving hospital either on the day or closer to the day that they're well enough to. Other priorities are, one links to the workforce remodel, and that one of the key bits for us is developing the maximising independence service, where we're bringing together our reablement services, our enablement services, and a range of other preventative services that we offer, with the aim that everybody who requires a new service or who has increased needs goes through that service first to see if we can get them back to and help them to gain their independence. Another key area is developing our integrated care teams. In Ageing Well, we've already done quite a lot of that in some places, but we've still got a way to go. And that's really working in those multidisciplinary community teams on strength-based work with people who have more complex needs. And I'm also keen that I work with the service to develop what our vision is for quality community services for older people. I'm really keen that we support more people at home and reduce reliance on more formal care, such as residential and nursing care. However, we do need to look at how we can make sure that people aren't isolated and that we're offering them more than just 4 home care calls a day. So that's a piece of work that I want to build on into the future. Can I have my final slide, please? I just wanted to finish my bit on a related story of someone who had been living independently and was the main carer for her daughter. She had vascular dementia. She became very depressed, was talking about suicide. On top of all that, she was diagnosed as COVID positive. But she wanted to go home after 10 weeks in an independent residential care home, having short-term care there, but only one person supported her, and that was her social worker, and six people were really advocating strongly that she should go into long-term residential care, and that included her family, who made 2 letters of complaint, her GP, her consultant, her care home manager, and her housing officer. And there was quite a lot to unpick because things had already been set in motion. For example, housing were terminating her tenancy, all her equipment and furniture had been returned. So there was a lot of work to start bringing those things back, on top of all the discussions with the family about their concerns and risks and worries. And a lot of discussions with the rest of the professional multidisciplinary team in terms of choice and risk and mental capacity. So what this shows me is that we really need to work a lot with our partners so that they're more understanding of what we can offer and how we can support people. And it also shows me that we need to get much more involved with people earlier on in their journeys so that we can help them make the right sorts of choices. That's the end of my slides, but I want to start and pick up on the question that was raised about the hospital discharge, and I think Melanie also wanted to come in on that. So we don't have specific data that could track in the way that Councillor Martin suggested in terms of how many people were admitted who had COVID, who were COVID positive in hospital and who then discharged into care homes. What I can say is that we did work very early when we realised that there was an issue with infection in care homes, and we worked very rapidly with health to put in place a way that we could stop doing this and make sure it wasn't happening. Certainly all our social care staff were told not to do it very early on, and then what we did with health was we developed some criteria so that only homes who were able to meet specific criteria that would be assure us that they could support people who were COVID positive, would they take those people on board, and that was shared with health and rolled out through the joint care home and home care cell. So I'm going to pause there. I know Melanie had her hand up, so I don't know if you want to come in and add more onto that question, and then I'm happy to take any other question.
Corporate Director.
Yeah, it was just a note to say that I am on agenda item 7, talking in quite some detail about support to care homes, so I can really answer that element. Obviously, Sue's particularly interested in hospital discharge, and I'll talk through, if appropriate, about how we've got assurance from health colleagues through the process about safe discharge.
Thank you, Mel. Councillor Martin, are you happy for it to be dealt with later on?
Yeah, I suppose so, Chair. I just wanted to really find out how many patients were moved on, whether they had COVID or not.
Yeah, thank you. We'll pick that up at the next agenda item. Councillor Doddy, please.
Thanks very much. We talked earlier on about opportunistic opportunities to improve things. We talked about what we'd learned from COVID and the absolute crucial element of retaining those things that have worked exceptionally well and not losing those by returning to what we've always done. I think particularly around this area, so we've got a recent study showing that something like a fifth of people, when surveyed, who were over the age of 60, said they would not go into retirement or nursing home care in the future. I think that the staggering death rate in the homes have certainly changed people's attitude. It's far from being a sort of a respite from the problems of being at home. They're now being seen as more of a challenge in terms of health. And I think it's an excellent opportunity to look at the whole model of care as people get older, and the model of nursing home and residential care home being, as it's always been, has got to be questioned in that. In order to achieve that, there'll be a tremendous requirement for people to stay at home. One of the possibilities is they stay more with their relatives and their families, and we go back to some form of multi-generational living. The second is that we improve the duration and the amount of support that exists in homes. It's incredibly expensive to keep people with 24-hour care in their own homes, but we're now seeing that that model of care where we provide increased number of hours, increased number of services needs to improve in order to change the desires of the public going forward. Certainly you mentioned around virtual care and around technology, perhaps bridging the gap between what was long periods of time of isolation and loneliness. And I think that it would be a great insult to those people who have perished from COVID for us not to use this as an opportunity to, obviously, we'll need to plunder the Better Care Fund, we'll need to plunder the integrated care services for a huge investment in social care through the council. But this is the lever, this is the opportunity that's always been required for proper funding for safe care of an elderly population, not being drawn back by default to a system which has just existed because it's existed for so many years. And my view is a future of people more being looked after in the community with increased hours, with increased resources, with increased technology, and most importantly, with increased funding. And I think that's the thing that I can see coming out of the COVID crisis. I don't know what your opinion is, Sue.
Sue, please.
Yes, I mean, I absolutely agree with the sentiments that we should really be supporting many more people at home. I look forward to an announcement from national government about a more sustainable funding for social care, because I think that's one of the things that has held us back. It's obviously had a massive, quite an impact on the residential care market. We already had quite a high number of vacancies in Nottinghamshire. So I agree. I think this is so part of the plan is that it's an opportunity to talk to the sector and look at more creative models of residential care as well, and things that are maybe more multi-generational and look quite differently to what they do now. also, as I set out in the presentation, looking at what that model of independent living could be. And again, we could do something quite creative around that. What we do need to bear in mind, though, is that the housing sector, particularly around social housing, is experiencing difficulties itself at the moment. So we'll need to work closely with partners on that, because it could be quite a hurdle for us as we move forward. But certainly now is the time to set out what our vision and aims are around that. So I do agree.
Thank you, Sue. Service Director Ainsley McDonald, please.
Good morning, everybody. So following Sue's discussion around ageing well, I'll take you through the priorities for our Living Well services. So the priorities for the Living Well service over the next 9 to 12 months. Firstly, the implementation of the new Living Well model from the 1st of September, which Sue has mentioned. If you remember, the new model is quite different to the structure that we have in place now, and will bring together social work staff from a range of specialist areas, which will be a particular benefit to people with complex and coexisting needs. Additionally, the new model will also be very locally focused, and teams will be aligned with local primary care networks, which Ageing Well already have in place. And that will mean that actually they can work much more closely with a range of partners, not just health, but also housing and the voluntary sector as well. One of the things that we've seen through the COVID period is that actually a number of our partnerships have really strengthened, because agencies have had to really pull together to meet the demands and challenges that we've come up against. A number of our partnerships have become much stronger through that process, even though we haven't been able to actually see one another face to face, because we've been able to quite quickly gather together using Teams, etc. So that's something that we've now got a good basis to take forward. We've seen quite a lot of creative support planning during the coronavirus period. Staff have had to be really flexible and creative in how they support people, and we want to embed the learning from that as we go forward. All of the sort of usual arrangements have been, to a great degree thrown in the air, and we've had to think very differently about people and how we meet their needs in a sort of socially distanced way. And there's been some real good models that have come out of that. We've also got a number of key areas of strategic work that we need to focus on over the next 6 to 9 months. And you'll see on the slide, we've got mental health, autism, transforming care, preparing for adulthood, housing, employment, and technology-enabled care. A number of those areas of work had already started before the COVID period, but obviously a lot of it was put on the back burner. So we need to get things back on track now and start looking forward. Can I have the next slide, please? I wanted to share this example with you. This is Junior, and this is a really good example of a positive situation arising from a negative one. This was shared with me by the Newark Community Learning Disability team. Junior would normally attend day services and short breaks services on a regular basis, but they had to close quite quickly as we went into lockdown. His parents were furloughed, so were able to support him at home, but they had to create a completely new support plan for Junior, which was obviously focused around the family home and spending time together. So they thought about all of the things that Junior enjoys, and they put together a programme of activities throughout the week. And I think the quote from Junior's mum at the last bullet point really typifies the success of this. You know, they were forced into a situation, but actually they feel that they've learned so much more about Junior, and he was so calm and, you know, so chilled throughout the period, despite you know, the stresses and the sort of disruption to his normal situation. And they've really learned that he thrives with more independence, and they feel that it's transformed them as a family, and that they've been able to reconnect with them again. So I think, you know, that's just one example, but there are numerous similar examples where, you know, we've been forced into a situation of having to support people differently, but actually that's in a lot of cases it's been an opportunity to completely relook at what we do. Can I have the next slide, please? For our provider services, so our day services, short breaks, other residential services, shared lives, etc., our priority right now is to develop a recovery plan which sets out how we'll support people whilst our buildings remain compromised. We still have social distancing measures in place, so we're working on the buildings now to make them COVID friendly, if you like. So we've got, you know, marked floors and, you know, moved furniture around, etc. Because we are keen to bring people back into our services as soon as we can. However, we do need to do that in a safe way and in a way that follows the guidance. We did have some guidance published on Friday by the Social Care Institute for Excellence about how to reopen day services. So we will take that into account as we go forward with our planning. We are assessing the needs and risks of all people that would normally use our services so that we can establish the best way to support them. Now, as I said, we've had a number of examples where actually people are doing very different things now, and we do need to take that into account, that actually for some people they may wish to carry on with the new arrangements that they've got in place. So we will work through with every individual and their family to look at what the best offer is for them. All of our services have had to significantly change their operating model during COVID. So day services have provided both a remote service using technology to engage people in a whole raft of activities. We've had quizzes, sing-songs, games, all of which people could come online and join in with. We tried to keep friendship groups together and provide them with a method of communication so that people don't lose touch. And we've also offered an outreach service to people at home, which has been really invaluable, particularly where people live at home with family carers, because that you know, break from caring has been much needed. Short breaks have continued to offer some respite to those that are in greatest need, and unfortunately we have had to take in a few people where actually their family carer has become ill and died as a result of COVID, and they're still with us whilst we look at longer term arrangements. But in addition to you know, the normal respite provision, our short break services also provided some of those short-term care beds that Sue talked about in order to support people being discharged from hospital. So they took older adults, including those who were COVID positive, and you know, had to set up special isolation wings in order to do that. So not only did this provide an invaluable resource, but actually it's also added to the skills and experience of the staff team. And we're really keen to retain that as we move forward. So we're considering how we can further develop our service offer based on that experience and potentially how we can open services up to a wider range of people and a wider range of needs. Bishop's Court Care and Support Centre, as you know, was due to close at the end of March. It was clear that beds would be needed in some form to support hospital discharge, so closure was delayed. However, the demand has really dropped off now. I think at the last count we only had 2 people in, so it's clear now that, you know, the beds are no longer needed in the way that they were. So we do plan to close the service at the end of August. But I have to say the staff did a remarkable job. They were 9 days from closure in March. The building was practically empty. Staff were, you know, ready to leave. But they, you know, very quickly brought furniture back in, got the service back up and running, and a number of staff stayed on despite, you know, having plans of their own beyond March. Our other services, such as Shared Lives, Church Street, County Horticulture, continue to operate as normally as possible. So, as I said, the focus now is to have a really clear plan for what the new normal might look like across all of our services. Can I have the next slide, please? So this is just a few examples of our residential services, and they were really on the front line, particularly where they were supporting and caring for people who were COVID positive. And it's been really successful. You know, the short breaks units having to very quickly set up isolation units. They'd never done that before. You know, they had to use their common sense and follow the guidance. And actually, Holly Street led the way on that and produced a video to help other services set up their own isolation areas. And I think one of the things that's kept people going is that staff have really supported one another. I mean, the picture of the staff at Windhill Lodge, you know, they said they've laughed and they've cried and they've laughed some more. And I think that's been really important throughout the whole period, that, you know, people have really supported one another through. Next slide, please. And then, as I said, our day services have done all manner of things to carry on supporting people. They have gone into people's homes. They've also made a real point of celebrating people's birthdays. And, you know, they've gone out with cards and cakes. They've decorated people's homes with balloons and, you know, had socially distanced sing-alongs outside people's houses. And that's been really important to keep people connected to the services. And the Brook Farm shop has continued to open throughout. I think in the first week of the pandemic, our footfall went up about, I think it quadrupled within the first week. So, you know, we've kept things going as well as we can. And the next thing, as I say, is to set out what the new normal looks like. So I'm happy to take any questions.
Thank you, Ainsley. I can't see any on my list. I'll just check with the clerk. No. Corporate Director, Melanie, please, for a summary of how we've responded. I also understand that you're having problems with your connection, so we'll see how it goes. Melanie, please.
Yeah, I also think we've got one more presentation to go from Grace, Councillor Harper as well. But yes, before we move on to recovery, I think it might be quite timely to summarise. So I think I'm particularly proud of the department. So many of the members on the call today we've kept in close contact with, but I think some less so. So I know many of you understand the pace at which we've been working, and I think
Chairman, I keep losing audio on this phone.
Yes, I think many of you will understand the pace we worked at and how intense it has been. So we've been very much in emergency incident response, and we still remain in that, which means we're still working very much within a command and control style. So there are still a range of activities that we're yet to stand up. So more around commissioning, strategic planning, and those other aspects which Grace will touch on how we do that. But I think, like I say, it's just to reiterate the pride I have in the staff team, the flexibility. Some people work tirelessly in the early weeks. It was particularly intense. And it's thanks to those that have been a great source of support. So good support from chairman and some of the opposition members in that journey. So it's just to say thank you, really. Grace is going to cover off how we're going to be standing services back up. What Grace will talk about is that we don't have any clear deadlines. We're still very much in response mode. But what we do have is a roadmap for how we're going to consider how we put things back on. But just to reiterate that point that we do have to prioritise, because we're still in response mode. We're not able to, we haven't got capacity to do everything possible. So I'll just pass you over to Grace if that's okay.
Thank you, Melanie. Councillor Woodhead, we've contacted IT. They'll be contacting you to discuss the problems with you. Thank you, Melanie. Grace, please.
Hello, good morning. I'm Grace, Director for Transformation and Service Improvement. Really pleased to be here this morning, my first meeting. So meet you those whom I haven't met. Slide, please. Okay, so part of my responsibility, what the department's recovery looks like. Colleagues have already talked about what they're doing specifically within their service areas. So just to give it a bit of a context, you'll be aware that there be some work going on around I'm the department's representative on that corporate recovery information group. But primarily, really, they've been around workforce, how we put the workforce around that, how we stand up, start using buildings again.
Grace, sorry, could you take your video off because you're breaking up? It might increase your volume signal if you turn your video off.
Okay. Okay, I'll try again. So I was is that any better, Chairman?
Yeah, that's a little bit better, thank you. Sorry to interrupt, but we was only getting patchy signal from you.
That's right. Let me see if I can put my volume up as well. Okay, I've put it on maximum, so hopefully that should help.
Yeah, that's a lot better. Thank you, Grace.
Okay. So in relation to the corporate recovery, there is obviously the different elements as highlighted on the slide, and as our department's representative in relation to that. In relation to adult social care and health recovery, so we covering adult social care, public health, and also commissioning, where commissioning have been having conversations with service providers in relation to how they set their services back up. And Jonathan talked at some length around the work that the local resilience forum are also doing, and within each of the individual cells there will be recovery planning as well. So this slide really is just to highlight the amount of activity relating to recovery, the need for us to ensure that we're linking in with everything that's going on. Can I? Okay, I put up this this statement which we've shared with the chairman before, but I think it's important in the context of what we are talking about and everything else that colleagues have and demonstrated, that since the declaration of the major incident, adult and social care and health has remained open be that obviously our operating models to ensure that we're adhering and guidelines. Safety has and remains one of the #1 priorities, but the most important thing here to state is that possible we have continued to support people who need us most. And, you know, in preparation for the emergency phase, I think from a corporate perspective, a little bit ahead of the game in terms of ensuring had started talking about thinking about how we progress and the services back up once we exit the emergency. So whilst we're still in the emergency period, recovery work has obviously quite a while. Can I have the next slide, please? Okay, so in relation to the departmental recovery, what we're conscious to do is to make sure that we have a clear plan really on how we are approaching the recovery. So we divided the recovery into 3 distinct phases. Phase 1 was about reviewing the the emergency models that had been implemented during the emergency phase. How we did that, engaging some of our stakeholders in terms of on how they have found the emergency models helped. The next stage was assess exit the emergency. By that I mean, you know, we did some and analyze, and I know Sue when she was talking about the process as an example. There's some elements whilst the social guidelines are in place, how further the interim service how we staff and others. Can I just check? Are you? Can you hear me okay, or am I still breaking up?
Yeah, you're still breaking up. Could I bring in the corporate director, please, Melanie?
Hi, Grace. What I think I'll do is I'll pick up from you, although my connection, I'm not sure it's going to be too much better, but I'll give it a go. I think, so Grace, please do drop any notes in the chat if there's something crucial that I've missed. I think what we're trying to say here is that we're taking a phased approach to the recovery because we're not clear at certain milestones yet. So a good example is we're not clear when we could operate day services in the way we used to operate in them fully. So for example, where you bring large groups of people together in a building. We're also not clear on how we could use office space again. So the government guidance currently is that its council offices should be closed generally to public access and not used as the main place to work. People should work remotely. So what we've tried to do is a phased approach, so where we look to restore and transform as government guidance changes or as we learn to live with COVID. So it's effectively what we're trying to say on this slide. Next slide, please. And this highlights what we've done. So we've been reviewing where we've gotten to, because there are some things that have worked particularly well. So for example, using Teams has had some benefit in preventing people from moving around the county and has kept close contact. It's also enabled staff to work much more flexibly. However, there are some areas of the service that Ames has covered that have been considerably disrupted. So we reviewed what we've learned. We're still in that emergency phase, at least until the end of July. And so we're very much operating under the emergency models for the service. And as we're doing that, we're going to be reviewing what we've learned. So what are the things that we did before that we no longer want to go back to? So all of the things that we want to restart, so effectively we just switch it back on as it was. And I think really there's more for us from an adult's perspective. There's more services in the box. We're wanting to shift what we can. One of the big gaps for us, as I mentioned just now in my summary, is about communication and engagement. So we've been in the emergency operating. I've had to use emergency powers, which I'll be describing in the next report. So what we haven't done is the usual routes about co-production, involving people in decision making and discussing with people. We've made decisions and then told people what we've done. So that will be an important part of our recovery as we move forward. But really we're expecting to be working on the recovery phase from August and September and slowly standing things back up. Although I do, like I said, I do foresee that there are some service areas that we won't recover fully for some time. I think the current thinking is that from the Adult Social Care Task Force from David Pearson is that we're planning for that phase being another 12 calendar months. So it could be some time before adult social care behaves in the way it used to, if indeed it does again. Next slide, please. And so our financial position, and again, I'll be covering this in the next report, has been severely affected. So in report 7, I'm going to be talking through all of the areas where we've incurred additional costs. We have already spent over an additional 7 million, and that doesn't include costs of PPE, which have cost the council around 5 million estimation. We've also lost income. So whether that's about the contribution made to somebody's care, somebody's transport, and there's a whole raft of areas where we haven't generated the income that we'd expect to see. We also know there's some quite long-lasting impacts of COVID. So for example, housing provision is a particular risk within district and borough councils at the moment. So that impacts on our savings plan, because our savings are based on not using residential long-term care and moving alternative forms of accommodation, preferably housing. So as well as it meaning that we're going to probably see more demand for services in some areas, as Jonathan covered in his summary about the impacts on health, we're also expecting some of our usual pathways to be severely strained. So effectively, the council is expecting that gap in the financial plan to extend, and we're not really clear at this point how much of those costs will be mitigated by government. Next slide, please. So this is a particular slide. I think I've covered most of this around day centres. We know this is a real concern for people out there, particularly carers, who are wanting to get back into a normal pattern, particularly if they start to work again. So at the moment, people are furloughed, but that's likely to shift as people find work. And we also know that because of the social distancing rules, the fact that transport's more of a strain, the fact that many of the people we work with are vulnerable groups and in shielded groups, that the way that we used to run day services is not going to be feasible in the short term. So we've got a particular piece of work looking at that recovery and a particular risk assessment. Ainsley mentioned that in her presentation, and Jane Mackay has got a buildings readiness checklist to work through. I think running through this to me is a real discussion that we need to have with people. And in fact, we've got one of our first co-production sessions for a while this afternoon with Councillor Harper, myself, and groups of the existing partnership groups to have a discussion about experience. Because if you were to see some of the photos of day services with a table on its own marked out in yellow tape, you'd also question as to whether that's a good experience for somebody to receive support in that way. So there's now a chance, I think, for us to have a good debate with people about how are you, how can we meet your needs in the best way given that experience for you. Next slide, please. Sue's mentioned carers, but we know that carers are under strain. So some families have been coping amazingly through COVID, but others are finding it particularly difficult. And we know that mental health impact is significant. So carer support is going to be crucial for us in our recovery plans. Next slide, please. We've had some work in the ICSs around trying to understand mental health impact. And I think, as you all know, I lead on mental health nationally in the National Suicide Prevention Plan and for ADAS. So I think universally everybody accepts that there's mental health strain. So I think the problem's being quite well articulated at the moment is how I would describe it. I think the struggle really is on how we can tackle it. By that, what I mean is that we know that now the risk to mental health is moved. So people now are presenting that wouldn't have presented for support before. Women who are in their over 65 are becoming more of a risk than the previous suicide risk, which would have been middle-aged men. So that risk is shifting. So I think what people do know is that mental health has been affected, people are experiencing trauma, we're expecting there to be more demand. But what we don't yet have is some ready-made solutions on how to support people, particularly under social distancing. So this is going to be a huge priority across the council, indeed across CAM services, public health and adult services. Next slide, please. As Sue and Ainsley have mentioned, and indeed Jonathan, we've redeployed people. People are working remotely. They've been working over Teams in this way, which obviously today has had quite a few hiccups. And the experience of our workforce is quite varied. So some people have really taken to the new way of working. Some people have worked huge amount of hours. Some people haven't been utilised enough. Some people have had to struggle with caring responsibilities, childcare, home schooling. Others who live alone have felt very isolated. So what this tells us is that we need to really link closely with the work that Marge Towand is leading to look at how we support our workforce and how we recover, because the impact is quite huge on staff wellbeing. Next slide, please. So don't lose the slides, whoever was doing that, because I've got no idea what Grace was going to say on the next bit, so I'm winging it a little bit. But anyway, the next steps. So this is the process that we're going through. So we've got a recovery plan, which is part of the corporate recovery plan. And as Grace said, links really closely to the recovery plans in the ICS and the recovery plan in the LRF in terms of framing adults and public health. We're reviewing our services that are commissioned to understand their fit for purpose, what we need to change, how we work with providers to stand that back up. And I'll be talking about care homes in the next item. And then we need to work really clearly through risk assessment. So what's going to be crucial for us is understanding how we support people in a safe way, because clearly we're an employer as well as supporting people with their needs. So it's balancing that through clear risk assessment. I've just been told that's the final slide. I think I'd work that out, but thanks, Jenny, for the nudge. So I'm happy to take any questions on this, or indeed anything collectively about our departmental update that you've heard so far.
Thank you, Mel, and thank you very much, Grace, for all of your hard work in putting it all together, and thank you, Jenny, for doing the slides. We are having big problems this morning with the internet, but we are persevering and we will work our way through it. So thank you for that. And if I can just take the opportunity to publicly thank the Corporate Director, Melanie, service directors and all staff for their hard work over the last few months. They've risen to the challenge and have been a credit to this organisation. So a big thank you. And could you put that in the minutes, please, Clark? Thank you. Can I just check with the clerk? Are there any hands up that we've not seen? No, that's it then. Thank you very much. So we'll move to the vote. I can see all 22 members are with us, so that's okay. Do I have any votes against or any abstentions, please? Thank you. So that one's unanimous. Thank you very much. We'll now move on to item 7, support to care home providers, including care homes in Nottinghamshire. The report provides an overview of the support that was provided to care providers, including care homes, during the pandemic period, and the decisions taken by the Corporate Director for Adult Social Care and Health on behalf of the Council under emergency powers, and the implications of these. This includes information on the financial impact as far as this is known at present. The recommendation of the report, as set out on page 21 of the agenda pack, is that members consider whether any further information or actions are required in relation to decisions taken by the Corporate Director for Adult Social Care and Health on behalf of the Council under emergency powers in the period of March to June 2020. I formally move the recommendations. Could I have a seconder, please? That's Boyd. Thank you very much. Melanie, please.
Okay, so I do apologise. I missed virtually the first hour of the meeting, going in and out of the meeting. So some of these things will have been discussed earlier, and I won't be cited on it. So I might repeat myself or repeat others. So I do apologise if that's the case. But what this report tries to do is to pull together all of the decisions that I made under my emergency powers that drive a cost. And it also tries to cover off issues, particularly with care homes, because we know that has national attention. And Councillor Martin, if I don't answer the things you raise, because like I said, I was losing connection, please do remind me at the end to cover those off explicitly. So the report just describes that we started with a major incident on the 20th of March. What a roller coaster ride this has been since then. And it's just to give some assurance, really. First of all, that I have made the decision powers, but it's been in consultation with Councillor Harper, and then more recently with support from the vice chairs, and then briefings with the Labour group. So we have had some engagement of committee members in decision making, but not what you would call the usual decision making that you made. So just to give you that assurance. One of the big things that we did was develop an internal staffing pool. So we did this in two ways. The first is we identified staff within the council that we could redeploy to adult social care if needed. So if we had lots of people absent or services weren't resilient, and that had a cost attached to it, because that meant that we had to redeploy people from their roles. So there was an opportunity cost, but also we had to train people. So we had a training package for council staff that included introduction to adult social care, manual handling, and a whole raft of things that meant we could move them if needed. We also recruited a pool of relief staff. So this has a direct cost in terms of the cost of that recruitment and the cost of their salaries. And the aim of this redeployment pool is that we can field those staff where it's needed. So they have been redeployed to care homes who've had an outbreak. They've also supported, as Sue and Ainsley described, in some of the key service areas for internal services, particularly internal provider services. We've also made a number of decisions early on to support the care market with their financial sustainability, which some of the money that the councillors have been awarded by government has helped with, but it hasn't covered the full cost of that. So we did a number of things. We moved to paying on plan for activity rather than what was actually delivered in a service. And this has particular costs in home care. So that's a particular cost to the council. We set up a mechanism where providers could claim for additional COVID costs. So for example, claiming the cost of having to do a deep clean, staff being absent, and whatever they deemed relating to COVID, buying iPads for people to communicate. There's been a whole range of costs that have been implemented with that. And we also made sure we paid and brought forward all of the planned increases for the cost of care. So made sure all of those inflationary uplifts were put forward. So there's a summary at the back of the report that highlights how much is spent on there, the aspects supporting the market. So in paragraph 39, and you can see how that breaks down with an average of about 3.5 million just for paying on planned activity rather than the actual activity. I think Sue's covered really well the hospital discharge aspect of it. So really what I want to flag is some of that risk. And like I say, Councillor Martin may want to make sure I've covered his points that I couldn't hear quite well on the connection of the call. The NHS has been paying since the discharge guidance for all packages of care that have been made to support people home from hospital. So that has meant that we haven't had to fund that activity, but it does give us some risk in terms of whether that placement was the most appropriate. There was a lack of person choice. For example, somebody went to where it was deemed appropriate rather than where they may have chosen to be. Whether they are eligible for CHC, because continuing healthcare guidance has been stood down with the same discharge guidance, and whether they should make a contribution to their care. So there's a degree of financial risk to the local authority once recovery stands back up and those arrangements for health paying for those packages have ended. So what we've done to mitigate that is to make sure we undertake a financial assessment, although we don't implement the outcome of it, that we're aware of who we would need to pursue continuing healthcare for once the continuing healthcare is stood back up. and to make sure that our MIS service, the Maximising Independent Service, is ready to start enablement and re-ablement to any placements. I think just to cover off some of the care home support, we've been working really closely with the clinical commissioning group of how we support care homes. And we've had to have quite considerable assurance to government about how we're doing that. And I talk about that in the template that we've submitted and that I now get daily monitoring on by the regional care home cell to look at how we're doing. So that monitors outbreaks, it monitors training that staff have had. But I think it's fair to say that the early weeks of the arrangements were quite bumpy with health. It took a while to get to the place where we could work jointly. It also took a while to get to the place where the acute hospitals weren't making their own discharge arrangements outside of the arrangements we made. So if I can take this opportunity to remind you that around 50% of the care homes in Nottinghamshire are funded either by the CCG or ourselves. The other 50% is funded by people themselves. So that's a part of the market that we had no control of in the early days of the pandemic. So if an acute hospital discharged somebody into that home, we had no ability to do that. In fact, we don't even know when that's happened. So what we don't have is data, Councillor Martin, about how many people would have been discharged, whether they were tested. That is just information that isn't there because we're not cited on that whole activity. We're only cited on the activity that is activity we support and fund. The infection control grant, that came in 2 tranches to go to the market. And the Adult Social Care Task Force, headed by David Pearson, is responsible for monitoring the ability for providers to meet that requirement. We don't have any ability or levers over care homes to make sure they're abiding by that guidance. And we don't have any control over how they use this money, but the guidance puts significant requirements upon them as businesses themselves to do that. So we are involved in administering that money and making sure it gets out to them, and we've fulfilled that. I think the last thing to do is just highlight some of the risks in the social care market. So I mentioned about the degree of self-funders there are for Nottinghamshire care homes. So what we don't have any control over in the council is vacancies for care homes, and neither do we want to start funding the cost of those vacancies because the cost would be extraordinarily huge for the county council. We also know that demand for care homes is reduced. So older adults particularly are choosing not to go into care homes, and but honestly, you can understand some of the decision making in families around that. So what we are expecting to see is that the market will be affected financially. There will be care homes that probably weren't viable financially before COVID, and their financial pressure will increase. But there may also be homes that before were quite popular, but they're also going to see their admissions reduce. So there is going to be quite a considerable amount of risk in the market going forward. We've also talked about day services and how some of those services may not be viable into the short to medium term. A number of those are voluntary organisations or charities, and it's purely because they may have relied on a very simple building-based service in quite a small area, and they're just not going to be able to open that up into the short term. So the focus that we're going to have as a department on sustaining the market, supporting planned failure, because I think we are going to have to accept that some services will need to close and fail, whilst making sure that we can support those that are viable and fit for purpose. I think it's going to be a particular priority for us as a department going forward. There's a bit of a whistle-stop tour for the document you've seen in front of you. And the final thing to note is the costs on page 6 were only till the end of May. They're obviously quite substantial now. We're in mid-July. So you can kind of add 6 weeks of extra cost onto that to give you an idea of where we are with that financially. But so happy to take some questions.
Thank you, Mel. Thanks for that report. I've got Councillor David Martin. If you could let us know if your questions are answered, please, David, or if you want further information. So we'll start off with Councillor Martin, then Councillor Sissons, then Councillor Wise, please.
Yeah, thank you. Thank you, Councillor Harper. You'll have to indulge me because, yeah, I know some of the questions have been partially answered, but if we're responsible for 50% of the output, then surely, you know, we should have some data on that. You know, and the other thing is, who was responsible for testing people leaving hospitals then if we weren't? You know, and that was my other question, because somebody's got to be accountable, because you changed, the system was changed for a rapid release, and I'm worried that somebody had to be responsible for that element of it. My fourth question was how many patients were moved from hospital to care homes, but obviously we're responsible for 50% of them. The other thing is, you've got a massively difficult job now, and I think my second set of questions really are about the costs and the support that we've had. So,
Dr. Doddy?
Yeah, because the county council spends £12 million a year more on social care than we raise in council tax, and as the government has delayed the green paper 6 times, we're still wandering around, not really knowing where we're going. And also, you know, do you believe that the £22 million is an equitable share of the 1.6 billion that was offered by the government? And likely the 35% decrease in the second payment, which was only 14.6 million, you know, making a total of 36.6 million, when in actual fact it's cost nearly 50 million. We still have a 13 million shortfall, and these are only the recent. I would suspect these figures are still growing, you know, because we're not completely out of it yet. So we've got a 13 million pound shortfall in income between grants and what the county councils had to support, and yet the minister, Robert Jenrick, promised to support all county councils through this crisis without us bearing any financial burden, and yet here we are increasing the MTFS, which is basically a good as guess as you can get at best, because it's gone from 28.3 million to 54.5 deficit. It's where are we going to get this support? Who actually communicated with Helen Wheatley, the Minister for the Care at the Department of Health and Social Care, in this period, in order to make sure that we were getting the right kind of funding? Because it's obviously we've still got a big shortfall to find.
Thank you, Councillor Martin. Councillor Doddy, just for information, we've muted you, so you'll need to unmute yourself if you want to speak. Corporate Director, please.
Clearly, I can't comment on some of the political questions, but in terms of the costs, so we haven't yet finished incurring COVID costs. What we are doing is trying to mitigate against some of those. So I described some of those methods about making sure we financially assess people, making sure we can decommission services that are no longer fit for purpose. We've also ended some of the provider arrangements. So we said that we would go back to paying on activity rather than plan at the beginning of July. So we've enacted some of those, but we are still supporting with COVID related costs. In terms of how we've addressed this, so Anthony May raises things as Chief Executive through the Chief Executive Network and through ACCI. I raise things through the my connections with the Adult Social Care Task Force. So we are, and through ADAS. So we are escalating some of those issues about what the actual cost of these are. And we are expecting there to be some further guidance on supporting infection control in care homes, and with some guidance about how some of that will be funded. And I believe that Finance and Major Contracts Committee are considering the overall aspects to the MTFS. So what I don't have in front of me is all of the detail, but Nigel will be presenting those to that committee, which I believe is happening in the next week. So what I suggest, Councillor Martin, is some of those questions are best fielded in that direction when it relates more broadly to the MTFS. But no, I think for adult social care, those additional funding has not met some of the cost. Like I say, some of that is because of loss of income and the way we're organised as a council, rather than just pure COVID, and also the effect of decisions in housing that has back into adult social care. So I think that covers off that bundle of questions about cost and grant funding, but if it hasn't, do come back to me. In terms of who's responsible for testing on discharge, well, the NHS is responsible for testing people rather than us in care homes. And the testing on discharge didn't come in. I mean, you've got to remember that we've been in an emergency phase and different decisions are coming nationally at different points. So I think the testing for people on discharge didn't happen until towards the end of March. So discharges would have been happening at that point. So there are some things that we've counted that's been relevant to that period of time and some things that we haven't. What we did have in place for care homes from day one was a dashboard that we developed over time, and that gave us visibility of who had a diagnosis of COVID in a care home, what percentage of their workforce they had at work, the percentage of their workforce that were reporting COVID symptoms, because at that time we didn't have testing for COVID at all. So we've had some data that we've been able to monitor, and it's been of national best practice. I've been referenced in the Adult Social Care Task Force. There's been other things that we just either haven't been available nationally and still aren't, or things that we wouldn't have been able to count because we haven't got access to that level of information. Does that make sense? I'm not trying to ignore a question, but we simply don't have the data.
Thank you, Mel. Council assistance, please, Andy.
Thank you, Chairman. I just wanted to make a couple of comments. Firstly, I must declare an interest here because my wife works in a care home. But what I'm about to say, I don't think affects the council as such.
I've just checked, Andy, and it's okay. Carry on.
Right, thank you. I just thought I'd better mention that before I spoke. There's a lot of talk about accountability and who did what and when, and I think there was a lot of the problem was that we didn't know how this virus worked, and you know, it was difficult to operate in the emergency situation. Some decisions might have been wrong, but you know, were rapidly learnt from. Anyway, what I wanted to say was, I'm not going to say anything that breaches confidentiality. My wife has told me that in the care home setting, a lot of people weren't turning into work simply because they were frightened of contracting the virus and passing it to their families. But what I wanted to say was that I wanted to mention the staff that were county council staff that were deployed to care homes, and the ones who turned up at my wife's place of work were excellent in that they were willing to take on any tasks, were very enthusiastic about fulfilling the role. Obviously, they didn't have quite the one-to-one knowledge that the regular care staff have. They get to know a person, what time they would like to go to bed, things like that. But the staff that were deployed from the county were excellent, and no complaints in that direction. So I just wanted to make that bit of positive feedback. One or two things I have learned, which I will not speak about, that I can pass on to the market management quality team at some stage that I would like to pass over. But that was it really, Chairman, just the positive feedback from the county council staff who were deployed. Thank you.
Thank you, Andy. Councillor Wise, Muriel, please.
Thank you, Chair. And I do apologise for missing quite a bit of Sue and Ainsley and Grace's presentation, because I had, as I explained, I needed a phone conversation with my GP, which went on longer than I thought.
Yeah, can I just say, Muriel, just for the information of any public listening, that you did declare that at the start of the meeting and it was an urgent appointment.
Yes.
Muriel, you've
got to mute.
I think I've just got one question, and I apologise if it's been covered already. I think it's incredible that you're planning for the future when you've been whammed by such a huge change in demand for our services, and it seems to me, from a layperson's point of view, that it must be difficult to plan long term, because we've had one round of the infections. We don't know if there'll be another round. So I suppose my general question is how are you approaching the planning in the longer term? Are you really only planning for the medium term, say the next year or so? Because presumably in terms of day centres and older people going to the respite centres, that was a response to the first round of the virus. Whether those changes are useful in the longer term must be quite difficult to judge. So in terms of, in paragraph 9, you just explained about the appointment of temporary staff. On what basis are we employing those people? What, in a way, what does temporary mean in this context? And I suppose, just in a more focused question, with the number of, has there been a large number of older people going to the respite centres, and how's that working out? Is it something that we might do more of in the future? Because it has been talked about, hasn't it, of having more of a mix of people having respite care. Is that something we continue as well? Thank you.
And with the last question, I'll ask Ainsley to come in after me, because I know Ainsley's thought there's been some really good learning for respite through that time. So in terms of the relief pool of staff, so they're paid with a similar salary to their banding, and they are generally relief staff. And we know there's a proportion of them that will be looking to return to their normal type of work once their normal type of work is resumed. But we're also hoping, A, to maintain the pool, because we know we're going to need that capacity into the medium term, particularly given we don't know about whether we'll have a local outbreak and what that would look like. But also we'd like to try and recruit people into vacant posts if we can, because they've been particularly successful. And this campaign of recruitment we did on a values base rather than an experience base. And we've actually recruited, as you've heard from Councillor Sissons, some staff members that are particularly successful. So there's some learning there for that one. And in terms of planning, I think what we're trying to do, Councillor Vice, is a bit of both. So if we can stand up work where we can, because what we were doing before was important. So if we take the employment and health work, we've given that no attention. But we do know that post the pandemic, people's employment opportunities, if you have a disability or a care leaver, they're going to be even more strained than they were before. So we're kind of aware of some of this impact on the population and inequalities widening. So where we can, we're going to prioritise parts of the work. What I don't think we can do is fully stand up all of the strategic work we were doing before, but what we want to do is pick those areas that we know will give us some big gains. But in the short term, our priority will be about community support, so reshaping what that means to people, whether that's carer support and public health commission services. So how can we do that safely? The discharge to assess, so how do we make sure we keep the good work that Sue has outlined? And then clearly for public health, the priority has to be the local outbreak management plans. We've got to be really mindful that those three things are the focus, that we're not going to be able to do everything. But like I say, we're hoping to stand other pieces of work up around that.
Thank you.
And would you like to comment about some of the learning from the short breaks?
Thank you.
Yeah. So what we've done, Muriel, is we've been quite flexible with how we've used the short breaks units. So the focus was more on how we responded to the emergency, and there was an absolute need for short-term care beds for people coming from hospital. So we weren't so much providing respite care to older adults, it was short-term care following discharge. But the team really rose to that and really enjoyed it. Not only did they have older adults, they also had younger adults with other conditions. So, for example, we had a young lady with Huntington's disease, again, not something that the team had dealt with before. But as new people came in, you know, they learned, they grew as a team, and they're really keen that actually, you know, going forward, we try and incorporate that into the model as we go into, you know, sort of the next phase. I think the other thing that it's demonstrated is that we can stand things up very, very quickly. So if, you know, as you say, we were to have a second wave or another peak, we can certainly stand up the services that we put in place and be confident that we can do that. You know, as I say, we had to set up isolation units on the basis of no experience and no prior knowledge, which we did, and that was incredibly successful. So I know that we can do that again.
Thank you.
Thank you. Is that it, Mel?
Yeah, thank you. Just also to add my welcome to Grace joining the team. It was such a good decision to bring her in to help us move forward as well. And yeah, I'm sure she'll bring great added value to the looking forward. Thank you. Thank you both.
Thank you, Muriel, and thanks for reminding us to announce that. And yeah, good work. Thank you. Councillor Martin, you've already spoken once on the subject. Is it on this subject?
Yeah, it's a point of clarification, really.
Yeah, that's fine. Okay.
So can you confirm then, Mel, that after receiving 36.6 million, the county council is still around 13 million out of pocket so far? And where are those figures up to? Are they recent, or how many weeks behind are they?
Sorry, which paragraph in the report do you want me to clarify? I can't see that.
It was on the slide. It was on your slideshow.
Oh, right, okay. Yeah, those figures were accurate at the time that we created the presentation. But as I said, that what we've got is a moving feast. We haven't. Those slides were before the latest confirmation of additional local government funding, and what we have is a potential risk to adult social care of cost, which varies between something like 3 million and 12 million. We're taking mitigating actions, but until we're out of the emergency phase, which we're still in, and we understand what the recovery looks like, I can't quantify exactly what those costs are going to be.
Yeah. Why was there such a large decrease in the first payment and the second one?
Sorry, Councillor Martin. What?
You know, we got 22 million on the first tranche, and we only got 14.6 million on the second one. Why was there such a large decrease? It's 35% less.
I can't comment on the decision making in government.
Right. Okay.
Thank you. According to my list, there's no more speakers, just clarification from the clerk. Thank you. So we'll move to the vote. Do I have any votes against, please? No. Any abstentions? Thank you. That is then carried. So we'll now move on to item 8, review of the Better Care Fund programme and use of Better Care Fund reserve for short-term transformation projects. The report seeks approval from committee for the workforce implications of proposed transformation projects, which will be funded from the Better Care Fund reserve. This relates to the extension of 2 existing posts within the department and the establishment of 1 temporary post. The report also provides a reminder of the purpose, makeup and budget for the Better Care Fund. The recommendations of the report are set out on page 26 of your agenda pack, and they are that committee approves the following workforce changes. 1, the temporary 1 full-time equivalent programme manager partnerships Band F post within the Integrated Strategic Commissioning and Service Improvement Directorate is extended until the end of September 2020 to allow for further review of the future requirements of this role. 2, the temporary 0.8 full-time equivalent business support officer grade 3 post is extended to the end of September 2020 to support recruitment and retention initiatives for frontline roles in social care. In addition to working on recruitment for the supply register, this post is supporting the development of a new relief care worker register for residential services and start. 3, a 0.8 full-time equivalent commissioning officer Band B post is established for 12 months to implement the Dementia Advanced Care Planning and Support Project. I formally move the recommendations. Do I have a seconder, please? That's Boyd. Thank you very much. Melanie, please introduce your report.
Thank you. I'll keep this brief. So we do have a timing issue here. So what I'm asking is to establish and extend roles based on the assumption that Health and Wellbeing Board will approve a paper I haven't yet taken because the meeting got cancelled and moved to later in the month that will approve the work. So it's just to note that there is a timing issue between the two boards. So the way it works is that the Health and Wellbeing Board approve use of the Better Care Fund, Adults and Public Health Committee approve establishing of posts, decisions made in that board. So I'm not asking for permission to spend the BCF reserve, I'm asking permission to establish those roles, assuming Health and Wellbeing Board make that decision. I hope that's clear. Sounds a bit cumbersome, I know. So just to highlight that the temporary programme manager role was previously jointly funded by the CCGs and ourselves. They have withdrawn the funding, so we're going to be ending that role, but I want to temporarily extend it, take us past the emergency period, because we redeployed that person to be supporting hospital discharge. So I just need to extend the role to just allow for closure down of that previous work. Similarly, the business support officer is supporting the workforce remodelling work. We're now going live, as you heard from Sue, on the 1st of September. So I'm wanting to extend that role to the 1st of September to support us with implementing that model. And then the commissioning officer for dementia, that's a new post in line with the dementia strategy. And that's a post within public health that will help us with advanced care planning. So I don't have anything further to add on the report.
Thank you, Melanie. I've got no hands up. Yeah, I have. I've got Councillor David Martin, please.
Yeah, thank you, Chair. I think all these posts are well thought out, especially I've welcomed the dementia advice care planning strategy. That's a really high priority, I think. So thanks for bringing them to us, Mel. Thank you.
Thank you, Councillor Martin. I've got no further hands up. No, I've just confirmed with the clerk. So we'll move it to the vote. I formally move the recommendations. That's been moved earlier. Do I have any votes abstaining, please? Any votes against? That's unanimous. Thank you very much. Thank you. We'll now move on to the work programme. The recommendation of the report as set out on page 40 of the agenda pack is that the committee considers whether any amendments are required to the work programme. I formally move the recommendation. Do I have a seconder, please? That's Councillor Purdue Horan. Thank you. I'll just check with the clerk. Are there any changes to the work programme arising from our discussions today, please?
Nothing additional today.
Do any members have any comments or questions? Thank you. We'll move that to the vote. Anybody abstaining? None. Anybody voting against? That's none. That's unanimous. Thank you very much. That concludes the business of the committee. Thank you for attending. And for those viewing online, we have had major problems with the internet this morning, as everybody's found out. We realise that is out of our control. That's not under anybody's control. So thank you very much for persevering with it, and thank you for everyone that spoke and everyone that's attended. So thank you very much. The recording is now stopping. Thank you.